Dear audience, thank you for joining me today. I'm going to talk about my field of research, the role of advanced hemodynamic monitoring in critically ill patients. First of all, here is a short overview of my first research. Mortality of critically ill patients with shock reaches 60%. Therefore, hemodynamic monitoring of these patients has a crucial importance for accurate interventions. However, benefits are uncertain. Our systematic review and meta-analysis showed that with the use of advanced hemodynamic monitoring, the odds of mortality can be significantly reduced in the ICU. This way, advanced hemodynamic monitoring should be implemented in shock management. Further research should focus on identifying the shock phenotype that benefits the most and also develop more accurate and less invasive devices. I'm Liliána Nagy, medical doctor and MD PhD student here at Semmelweis University Department of the Anesthesiology and Intensive Therapy. I have a vision of keeping critically ill patients in highest safety, and I would like to achieve this aim by using accurate monitoring for accurate condition assessment. This year I started 2 projects about hemodynamic monitoring, one in the intensive care unit and one during anesthesia. Both would be systematic reviews and meta-analysis. Let me start with my first project, where I'm investigating the efficacy and safety of advanced versus conventional hemodynamic monitoring in patients with shock. The problem is that shock affects 10% of hospitalized patients, and out of 10 affected people, 3 to 6 die, depending on the type of the shock. The main cause of death in the acute phase is the hemodynamic instability, yet protocols regarding hemodynamic monitoring lack evidence. We know that conventional monitoring is widespread, but it's inaccurate during the centralization of the circulation. Cardiac output monitoring has a pathophysiological rationale, but it's invasive, cumbersome, it requires skilled personnel, and it's also expensive. We are missing its outcome benefits, so I aim to evaluate it in shock. Within advanced hemodynamic monitoring, we distinguish 3 kinds of devices. The most complex and the best devices operate on the principle of thermodilution, the pulmonary artery catheter, the PICO, and the LITCO device. We involve only these devices in this study. There are also non-calibrated devices that are less invasive, and theoretically ultrasound works as well, but it doesn't have a clinical relevance as a continuous monitoring method. My clinical question is if therapy guided by cardiac output measurement a safer and more efficient alternative to conventional one in high risk shock patients. Using the PICO framework, my hypothesis is that cardiac output measurement guided therapy has significantly improved outcomes. We conducted a systematic search in November on 3 databases using a systematic search key, and we found 12,000 results and ended up with 36 articles to analyze. The outcomes are expressed as odds ratios with 95% of confidence intervals and also weighted mean differences. We finished the analysis about mortality, length of stay, the need for different types of organ support, its length, and also the received fluid amounts. I would show the results about the in-hospital mortality, which is the number of deaths from admission until discharge from the hospital. The outcome is expressed in odds ratio. If it's higher than 1, it means that the patients in the advanced monitoring group are more likely to die. In this case, we analyzed 20 studies about more than 400,000 patients. In our case, the heterogeneity is high, but it's something we expect because we pull together different devices, different shock types, and different study designs, so we made the subgroups accordingly. The best effect was measured in the cardiogenic shock group receiving pulmonary artery catheter, but the overall odds ratio is 0.66, which means that the patients who receive advanced hemodynamic monitoring have a 34% lower chance to die, and it's also a huge thing in improving survival. The confidence intervals lie also on one side, so our results are mathematically significant too. In this manner, the implementing advanced hemodynamic monitoring in shock management would be useful. We also measured the need for different kinds of organ support. The inotropic support and the vasopressor support reflects best the hemodynamic instability, but we also measured the need for mechanical ventilation, non-invasive ventilation, renal replacement therapy, and mechanical circulatory support. In this case, we also measured it in odds ratios. If it's higher than 1, it means that the people in the advanced monitoring group are more likely to receive organ support. And we analyzed the data about 600,000 patients, and we see that looking at the overall odds ratios, almost all kinds of organ support was more needed in the advanced hemodynamic monitoring group. This means that these patients were in more severe condition, but they still had a better chance to survive. So our results are supported that advanced hemodynamic monitoring should be implemented into shock management. I'm pleased to share that our study might be the most comprehensive one on the topic so far, providing a definitive answer to a highly important clinical question. Moreover, our results can be immediately implemented into clinical practice. We face some limitations, like there were limited data on other types of shock and on the LITCO device as well. But we also had insufficient data to meta-analyze organ dysfunction scores. In conclusion, if the therapy is guided by cardiac output measurement, the odds of mortality can be significantly reduced. This way, it's important for clinical practice, supporting the early use of advanced hemodynamic monitoring in shock patients. Further research should focus on identifying the shock phenotype that benefits the most and develop more accurate, less invasive devices. Now that the research is done and all sections of the manuscript are written, I'm working on the final touches, and the planned submission is in 2 weeks. Then I'm planning to publish in a D1 journal, Annals of Intensive Care. Let me move forward to my second project, where I'm investigating the efficacy and safety of cardiac output and derived parameters guided therapy in high-risk surgical patients. The problem is that high-risk surgical patients represent 10% of overall cases, but they are responsible for about 80% of all perioperative deaths. Among these patients, monitoring oxygen delivery would be in major importance, so monitoring cardiac output would be pivotal, yet only 1 of 10 patients receive it. We know that conventional monitoring works well in low-risk surgeries, but they are inaccurate in high-risk ones. This way, the non-calibrated devices are minimally invasive, consisting only of an arterial line and a sensor attached to it. It's simple to use and also real-time. We are still missing its outcome benefits on postoperative outcomes, so I aim to evaluate it. Let me show the available devices again. Here, the thermodilution method using devices are not suitable, since they are very invasive and expensive to use them only for a couple of hours. In this project, we involved the non-calibrated devices with the FlowTrack and PulsioFlex devices, which are minimally invasive, and they are proper for monitoring during anesthesia. My clinical question is if when the perioperative therapy is guided by non-calibrated hemodynamic monitoring, is it safer and more efficient alternative to conventional one in high-risk surgical patients? Using the PICO framework, my hypothesis and the expected clinical implication is this kind of monitoring significantly improves postoperative outcomes. Now I'm in a preliminary search stage using a search key on free databases, and the key articles I found so far fit into the framework of my research. In summary, my goal seemed to be achievable, and I plan to finish the first project this September and the second project next year. And I would like to close my presentation with a quote: to keep our patients in highest safety, do to others as you would have them do to you. Thank you for your attention.
This high-level cardiac monitoring, what about the costs? Is it feasible? Like, there is a significant clinical advantage. You already demonstrated that. But for example, how are they available in intensive care units in Hungary?
Yeah, thank you. So actually the pulmonary artery catheter and the PICO device that we could involve in the meta-analysis, they are quite available and they are not that expensive. So this LitCo device is a different kind of category because it works with lithium and it's not that available in many hospitals. So I think only the big centers have them, but the PICO and the pulmonary artery catheter are available, and they actually are just cumbersome because they need to be implemented properly. But then they work with cold saline, so it's then the measurement is done. It's not that expensive itself.
I see. Thank you very much.
Thank you.
Yes.
Congratulations to the shocking results, I should say. And my question is that do you have a theory on why the most pronounced difference was in cardiogenic shock? I understand that you didn't have all the etiologies, but did you think about it, that why cardiogenic can be?
Yes, well, actually, this result was also surprising for us because we expected the best result in the septic shock group. And PICO is also more popular than the pulmonary artery catheter. Actually, yeah, so there were no specific reason behind. It was more useful. So actually, that's why I requested that further research should be done on the shock phenotype, because those studies that were implementing on these results were observational studies and also some registries, but they are rather on the one side of the forest plot, so there has to be a tendency.
Thank you. And a technical question is that what do you think, how much overlap will be between the high-risk surgery patient and the shock patient populations? Because high-risk surgery is probably going to shock some of them.
Yeah, yeah, I think there will be an overlapping, but actually that's why we are using different devices to make separate studies.
Story.
Yeah.
Thank you.
Thank you.